Welcome to session 6 of day 2 of RIO 2025. I'm Richard Schilling, live from our London studio. We're starting with a presentation debate session titled CIED Infection, What Makes a Good Referral? I'm delighted to welcome our faculty, Aldo Rinaldi and Jonathan Behar from here in London, and Joachim Weil from Lubeck in Germany. So, without delay, I will hand you over to our first presenter, Aldo, who will take us through CIED infections, costs and health implications of delayed referrals. Aldo, over to you.
Thank you very much, Richard, for your kind introduction. So I'm going to start off the session here really talking about device infection and both the healthcare implications and also the cost implications of delayed referral in the setting of device infection. These are my conflicts relative to this talk. So we're aware of the issues related to device infection, both in terms of systemic infection and pocket infection, as you see in these examples here, patients with device erosion. This is a really significant problem that we see in our patients receiving device therapy. And what we know is that device infection is a very serious complication and it's associated with increased morbidity and mortality, as well as healthcare costs. We also know there's very good data to support the fact that device removal or lead and system extraction is a class 1 indication in multiple guidelines. However, recent data would suggest that adherence to the guidelines for lead extraction is not always followed. So how much of a problem is device infection? So this data is a few years old, but this is US data in over 72,000 patients undergoing device implantation, showing that globally nearly 60,000 patients suffer with device infections, and the majority of these patients are undertreated. And if you look at the results over time, you'll see over 3 years in this large population, nearly 1 in 20 patients actually developed a device-related infection. So this is a relatively common problem. And what we know is that device infection is increasing. We see this in our daily practice as our patients become more elderly with more comorbidities. And again, strong data to show the increase in incidence of device infection over time. So if a patient has a device for 15 years, you can see in this analysis a 6% risk of infection over the lifetime, going up to over 10% over 25 years. And in patients having multiple generated changes and pocket manipulations, nearly 1 quarter of these patients will suffer with a device infection. Again, this shows that the complexity of the device is also important. When we see a higher risk or incidence of device infection with those patients with more complex devices, in terms of both ICDs and cardiac resynchronization devices. As I said earlier, the guidelines are very clear. These are multiple national and international guidelines showing that in the presence of either systemic or pocket infection, this is a class 1 indication for removal of all the hardware unless the patient is prohibited to undergo a lead extraction. And this is also shown in this recent ERA publication in terms of the diagnosis and treatment of infection, again propped in very early treatment with lead extraction and antibiotic treatment as being the only treatment to actually cure patients with device infection. So this slide shows you the outcomes of patients undergoing device infection lead extraction. This is in multiple studies. And what this shows is that lead extraction is both a very effective treatment. So in nearly all these series, you can see an over 95% clinical success rate with mostly complete device removal. And also you see a low risk of major procedural related complications. And in fact, very low risk of procedure related mortality, less than 1% in most series. So not only is this guideline indicated, but this is a very effective and safe treatment for our patients. But what we know is that there's relatively poor adherence to this. So this is US data. This is from the nationwide readmissions database, over 25,000 patients or healthcare episodes. These are patients who have CIED endocarditis, so systemic infection associated with their devices, between a period of 2016 and 2019. And what we see, I think, is very stark, that only 11% of patients presenting with device-related endocarditis actually underwent lead extraction. It's fair to say the proportion of lead extraction did increase over time from 7 to 15%. And what is very clear is if you undergo lead extraction, this is associated with significantly lower risk of mortality. We can see that the hazard ratio in those patients who underwent lead extraction in terms of all-cause mortality was, in fact, nearly half those patients that did not undergo lead extraction. And indeed, we have looked at this in the UK population as well. So this is data using HES statistics, so healthcare episode statistics, for patients with both device infection over a 10-year period from 2013 to 2023. We can see during this time, there are approximately 6,500 patients that are admitted to hospital in the UK with a device-related infection. We can see from the graph on the right that this incidence increases over time. And also we see the rate of lead extraction in these patients. And although this is increased compared to the previous data I showed you in the US, only approximately 50% of patients admitted with device-related infection actually undergo lead extraction. And does this matter? So this is a recent publication by Picconi et al. In Europace. So this is looking specifically at those patients that had device-related infection and underwent lead extraction. And this was defined as those undergoing lead extraction within 7 days, or those having a delayed lead extraction between 7 and 30 days, or those not undergoing lead extraction. This is Medicare data between 2006 and 2019 with patients with de novo CIED infections, at least 12 months after the implantation. And this model looked at both the healthcare utilization in terms of healthcare costs, but also patient outcomes. And what is very clearly seen this in nearly 10,000 patients is that the vast majority of these patients, so over 80% of these patients, did not undergo an early extraction within 30 days. In fact, only 13% of patients underwent extraction within 7 days, which is recommended. And in fact, a large proportion of these patients had a delayed extraction, if not no extraction. And this matters. If we divide these patients into those that underwent early extraction, delayed, or no extraction, we can see there are significant repercussions in terms of both outcomes for patients. They do worse. They have a higher risk of readmissions, higher risk of mortality. But also there's significant issues in terms of healthcare expenditure. As you can see, in the model shows that there is a much lower cost associated with early extraction rather than delayed or no extraction. These are the Kaplan-Meier curves, again showing the difference in terms of the cumulative incidence of the readmissions in these patients. You can see that those patients in red here that underwent early extraction had a much lower risk of the endpoint compared to delayed or no extraction. So again, strong evidence that early and timely treatment of these patients is associated with better outcomes and also better healthcare costs. And indeed, we have looked at this in the UK. Again, this is an analysis, a cost-effective or cost-utility analysis. So this is the decision tree for how we analyze this. So this looked at patients presenting with device-related infection and then either undergoing early extraction within 7 days versus a delayed or no extraction. So as I said, this was a decision analytic model based on UK NHS perspective. And the model inputs were from the literature and NHS cost data. And the outcomes were measured as adverse events that were avoided and also total costs over a 1-year time horizon. And we perform sensitivity analysis, both deterministic and probabilistic, to assess the model robustness. So if we look at the outcomes, and these are dichotomized both in terms of pocket infection and systemic infection, but essentially early extraction was superior clinically and economically versus delayed or no extraction. So if you look in terms of systemic infection, early extraction reduced costs significantly by over £750,000 and avoided 25 adverse events per 100 patients, with a significant reduction in mortality, with significant findings in terms of pocket infection. If we look at the sensitivity analysis, the outcomes at the bottom of this, we can see that the cluster in here for both systemic and pocket infection is in the southeast area. So not only is this cost effective, but this is actually a clinically dominant strategy. So undertaking early extraction is associated with better outcomes and reduced healthcare costs. This is the sensitivity analysis for both pocket and systemic infection, showing, in fact, that the main driver for the improvement in outcomes with an early extraction is basically a reduction in the use of antibiotics. So I'll finish and summarize at this point. I hope that I've shown you data to convince you that CIED infection is a significant complication associated with both increased morbidity, mortality, and healthcare costs. Complete device and lead removal is a class 1 indication in all national and international guidelines, but despite this, adherence to the guidelines is suboptimal. There is very good data to show that delayed referral and treatment is associated with increased morbidity and mortality, and indeed increased and significant healthcare costs. I would argue that this supports guideline recommendations for prompt extraction and need to improve adherence to evidence-based management of patients with CIED infection. Thank you for your attention.
Thanks, Aldo. That was really interesting. Presumably, the data you presented about the complexity of the device predicting the risk of infection is to do with the length of the procedure and the greater chance of infection introduction, the more difficult the procedure is. Is that a fair assumption, do you think?
Yeah, I think that's right, Richard. As you say, the more complex the device is, the longer the procedure, the potential for further re-interventions due to lead issues. So I think, yes, it's very important that we try to minimize the complexity as much as we can, I think, in these patients to reduce the chance of infection. And as you know, there are other adjuncts now we can use, such as antibiotic pockets as a prophylaxis to reduce infection at the time of implantation. But our other speakers may talk more about that.
And why is the infection delayed? Because I mean, it's quite striking, the data you showed, that the bulk of infection tends to appear quite late, whereas we're conventionally taught that, device infections are going to happen either at the time of the box change or at the time of the implant.
Yeah, I mean, I think we certainly see different types of presentations. As you say, you can see very early infections, often related to very virulent pathogens such as Staph aureus. But as you know, the less virulent infections. So if we think of the other staphylococcal species, sometimes they can be quite indolent and can take several years for them to present clinically. Also, sometimes patients may develop a device infection due to seeding from elsewhere rather than the implantation itself. So I think we can see different presentations depending on the underlying morbidity and types of patient presentations, right?
And one of the audience is asking for you to clarify, why is complete hardware removal essential for managing CIED infections?
Yeah, I think that's a really good question. I mean, what we know is that if you have device infection, you usually develop a biofilm on the device and the leads themselves. And using antibiotics themselves will not or cannot eradicate this biofilm. You cannot sterilize a patient with antibiotics. So you have to remove all the hardware from the patient's systemic system to afford that protection. So really, as I said, it really is a class 1 indication. The only time we wouldn't advocate that if it was too high a risk or the patient declined the treatment.
Now, one of the questions is it poor adherence and physician inertia? I mean, my impression is that, and maybe Joachim and Jonathan can comment on this as well, that as the SOPs and the guidelines get more demanding of what resource you need to take out these devices, it gets harder and harder to provide that resource. And so providing early extraction can be logistically quite challenging. What's your experience of that, Joachim?
Yeah, I think you're right. Not every hospital has the possibility to do extraction, but as an implanter, you should know where to send your patients. I think one of the problems, major problems, is that these patients initially show up with fever, and they might get into the internal medicine department, and the colleagues in this area may be overlooked that these patients already have a device implanted. And so this is my personal experience, at least in Germany, that in the initial where you send the patient to which ward, it really depends how fast you identify somebody with a CIED infection.
And Jonathan, what's your experience of providing the resource needed to do these lead extractions?
Yeah, thanks, Richard. So, I mean, I think that resources are obviously key and limited in many countries, but I think ultimately it's about having a good network. So one of the things I've learned certainly over the last few years is ensuring that you have a good network of colleagues, that if you're in a district referral hospital, you know who to refer to. And if you're in that receiving center, that you have the ability to timely get that patient over and in a timely fashion and prioritize the lead extraction procedure, which we've seen as demonstrated by Aldo, really does make a difference towards patient outcomes.
So before we go on, we've got 30 seconds before we go on to the next presentation. So Aldo, I'm going to throw you a curveball here. We're being asked by the audience, do you have any understanding or throw some light on infections in India and how they might be presenting as a problem?
Specifically in India?
Yeah, we've got a very wide audience here.
Yeah, I mean, well, I think I see no reason why it should be any different in India in terms of the risk of infection. So I think this is, as we've shown in the data, both in the US, Europe, the UK, this is a worldwide issues. But I couldn't specifically comment on India, Richard. I'm sorry.
Well, maybe one of our or some of our Indian audiences can put some comments in the question box and I can raise them later on. Thanks very much, Aldo. We're now going to hand over to Joachim, who's going to guide us through the state of play CIED. This is very difficult, by the way, keeping saying CIED infection at this time of night. CIED infection management, insights from a current European survey.
Yeah, thank you for introduction. Good evening to everyone, and thank you for joining this late session. Today, I would like to share insights from a very recent European survey on the management of CIED infection. And as we learned from the previous speaker, this is a topic of growing importance, given the impact of patient outcome and healthcare system. So I hope I can forward my slides, but I can't. So I have to ask Radcliffe. I can't forward my slides. Here, now it's okay. So this is my conflict of interest. So why CIED infection management matters? Next slide, please. So device-related infection are associated with high morbidity and mortality. And you have seen the original data from Aldo in the previous presentation. Guidelines, on the other hand, are very clear. Complete system removal is strongly recommended in most of the cases. Yet, in real-world practice, adherence remains inconsistent. So I think suboptimal care leads to recurrent infection, prolonged hospital stays, and higher costs that we have seen it earlier. So the question is, how well are physicians applying these recommendations and how can we improve? Therefore, the aim of our study, next slide, please. The aim of our study was to set out and evaluate the knowledge, behavior, and change over time. We compared 2 waves of survey from 2022 and 2024, focusing, and this is very important, focusing on non-extracting cardiologists and electrophysiologists. We wanted to see whether target educational interventions between 2022 and 2024 maybe made a difference and to identify persistent knowledge gaps. So how does this survey look like? Next slide, please. So we conducted a double-blinded online survey in 480 physicians across Germany, the UK, Italy, and France. Each participant answered a multiple-choice questions and were given 2 case vintages, so 2 clinical cases. The survey assessed guidelines awareness, diagnostic and therapeutic strategies, and concordance with class 1 recommendation. So before showing you the data, I would like to go a little bit more into the participants' characteristic. Next slide, please. The respondents were experienced physicians with a mean practice duration of 16 years post-fellowship. 80% of these worked in public hospitals, while 15 were in private hospitals, and another 2 or 3% identified in other institutional settings as their primary affiliation. General cardiologists and electrophysiologists differed in their experience. For example, electrophysiologists had personally implanted far more devices than general cardiologists. So to give you a number, it was 99% of the electrophysiologists implanting devices and only 50% of the cardiologists asked in this survey implanted by themselves. So both groups managed patients with suspected infection, as you can see in the slide here, and referral patterns varied still. This context helps us to interpret the difference in knowledge and practice. So how was the knowledge to guidelines? Next slide, please. As you can see here, most of the physicians recognize 4 of the 5 class 1 recommendations. And with the light bars, you can see the survey from 2022, and with the dark bars, the survey from 2024. However, electrophysiologists consistently show higher accuracy than general cardiologists. Importantly, this little increase we saw on these slides here was mainly driven by the EP group. So education is working, at least in the electrophysiology group, but there still gaps remain. However, complete device and lead removal, and this is the last 2 columns you see here, in all patients with valvular endocarditis or with or without lead involvement was answered correctly only in about 35 to 30%. So these words guideline knowledge, how does it look like with clinical scenarios? So next slide, please. In systemic infections, next slide. Can you give me the next slide, please? I can't, here. So in systemic infection, physicians were more likely to follow the guidelines. You see over 90% in the survey from 2022 and 2024. But next slide, in pocket infection, it looks quite different. Next slide, please. Adherence markedly dropped down, and unfortunately, I can't move my slide now. Yeah, here you see it. markedly dropped down to about 30%. Many physicians underestimated, therefore, the need for complete removal, treating pocket infection as less serious. So next slide, please. So let me put together the key findings. To summarize, awareness is improving, especially among electrophysiologists. However, pocket infections remained undertreated as shown in this survey. Decision-making is inconsistent and guidelines application varies depending on how cases are framed. This finding highlights the importance of continuous education and standardized protocols in every hospital. What are the implications for practice? Next slide, please. What needs to change? First, I think stronger dissemination of class 1 recommendations. Second, improved education for non-extracting physicians. I think this is a real task for the future. And third, standardized local protocols covering diagnosis, timing of extraction, and referral pathways to extraction centers. And we had this topic before. These steps can reduce variability and probably improve patient outcome. So to conclude, knowledge, next slide, please. Knowledge is improving, however, not enough. Only 1/3 of physicians knew that complete device removal is required in valvular endocarditis with and without lead involvement. Pocket infection still is commonly undertreated. So targeted education initiatives are essential in the future. Ultimately, better adherence means fewer complications, shorter hospital stay, and better outcomes for our patients. Thank you for your attention. Oh, I can't hear you.
Address. How do we address this gap in knowledge between the physicians looking after the patients and the experts? How do you address this?
Yeah, I think you address it in your personal network. So we are referring centers. We are not an extracting center, but still you have to train everyone in the hospital. It starts in the hospital. So you start with your fellows and your residents, and not only, I think, in your own department, which is cardiology department, maybe they're better used to the guidelines, but also in the departments where they see patients with infections. So it's an educational task. What you can do is round tables in the city, inviting, for example, cardiologists working in private practice to show the data to them.
And can I ask Jonathan whether this knowledge gap is something you have experience of? Is this an issue within the implanting and device management centers that don't extract devices?
Yeah, I mean, I think that, and I'll come on to this in the slides, but I think that it's really key to ensure everyone is educated. That includes the patient, the primary care physicians, their local hospitals. And I think that the further away patients present to centers that don't do lead extraction, the further they are away from really understanding the importance of timely referrals. So I think that education events like these are particularly important to ensure that everyone understands the importance of a timely referral where relevant.
And Joachim, I noticed that you saw that there was an improvement in knowledge, but there's still a big gap. Do you think that scrutiny by medical authorities in the UK, for example, coroners, does that influence things, or why has there been that improvement? Because I haven't seen a big push to, show these guidelines.
So I think, so as I mentioned in my talk, the increase in knowledge was basically driven by the electrophysiologists who in 100% did implantation of devices themselves. So cardiologists only did it in 50%. And I think people who are implanting devices, they're more aware now after the education the last couple of years on this specific topic, that they think about early referring these patients with fever and suspected infection of the device. I think in the future, maybe the electronic records in the hospital will help us to identify these patients also in other departments very early. So you could look for infection, you could look for fever, which is recorded in the electronic record, which is can be automatically extracted. And you usually know that patients have a device or not a device. And I think this is also something we should look at in the future.
I think that's a really great point, because we already have alerts for septicemia and renal problems, so that automatically pop up whenever we access the patient's notes. So I think that's a really great point and a really great idea. Do we know, and forgive my ignorance, what's people's understanding of the use of leadless and the management of endocarditis in patients with leadless devices, and how does the knowledge base and the questionnaires cover that?
So you maybe correct me, but as I'm aware, there are not too many data on infection of leadless devices. The only thing I know is that the possibility for infection is lower than in a conventional device. I don't know, because it's a relatively new, at least in Germany, device to implant. There are not too much experience so far. I don't know, maybe Jonathan or Aldo has more information on that than myself.
Yeah, Aldo, what about you? And in endocarditis patients presenting with a leadless device, how do you manage those patients?
Yeah, excellent question. No, I agree with Joachim. I mean, it's a pretty rare occurrence. I'm aware that there are some cases in the literature, although it is extremely rare. Of course, pocket infection is not an issue, but systemic infection can occur. But thankfully, it is very rare. I think the other issue in terms of leadless that we tend to see in the extraction area now is the use of leadless in those patients that have had an extraction or have had an infection, both in terms of reducing the risk of infection going forward, but also in terms of management when they're in the hospital. So often patients will have long admissions due to the requirement for reimplantation, and it may be that a much earlier strategy can be adopted, giving these patients a leadless device and allowing them to be discharged at an earlier stage, I think. But I think as more leadless devices are used, I think we're likely to see episodes of infection, and it'll be interesting to see how we can treat those going forward.
And Jonathan, have you got an experience of endocarditis in patients with previously implanted leadless devices and how you might manage those?
Yeah, so I haven't seen directly any endocarditis patients that have a leadless device in. So they are, as Aldo said, incredibly rare. One would assume that would necessitate removal, and there's now some good data demonstrating removal techniques and success with leadless devices. But the frequency of it is very, very rare. Certainly in the literature, our microbiologists are very keen for us to implant these because there seems to be such a low recurrence rate of infection that we're encouraged to do so. And I think it's a very good option for these patients.
Great. Well, I think in just a second, we're going to move on to your talk, Jonathan. We have a question from an old friend of rhythm intervention online, Ernest Lau, and maybe you'll address that in your presentation, because he's asking, should capsulectomy be done during a complete system extraction? So I won't ask you to answer that now. I'll ask you to give your talk which is enhancing CIED infection detection and treatment. And if it wasn't included in that, then maybe we can address that question during the discussion. Over to you, Jonathan.
Thank you. Thank you very much, Richard, and thanks, RIO, for the invitation. So these are my conflicts of interest relative to this talk. I'm going to first talk about a case that hopefully sets the scene, and I think really highlights what already has been mentioned by the previous two speakers. So a 64-year-old gentleman with dilated cardiomyopathy, atrial fibrillation, and a biventricular defibrillator implant in 2017, presented to a local hospital with evidence of confusion, arm weakness, and aphasia. And the working diagnosis for this gentleman at the time was encephalitis. He was also feverish and had a negative lumbar puncture at the time. He did also, however, have evidence of staphylococcal bacteremia on one set of blood cultures, and he was treated initially with a combination of flucoxacillin, ceftriaxone, and acyclovir. He had quite a long hospital stay, as you can see, and he was discharged 3 weeks later. And he underwent a further 2 weeks at home before he re-presented, now with evidence of a breach in the skin and further evidence of staphylococcal aureus bacteremia in several blood cultures over successive days. And at this point, the penny very much dropped, and the suggestion was that this gentleman had a CIED related bacteremia and very possibly endocarditis. He was then referred to us, our extraction center, and transferred over urgently and underwent lead extraction the following week. As you can see, he had 8-year-old dual col CRTD, and actually this was probably one of the easier extractions that I've done. One might expect that these leads would be quite tough to extract, quite fibrotic, but in fact the cuffs were completely detached from the muscle. The leads were removed under tension alone, and thankfully there was no requirement for powered sheaths. Indeed, the tips and the wound grew Staphylococcus aureus and confirmed that this was a MSSA CIED-related endocarditis. As is often the case with these patients, he was discharged home several weeks after this, and you can see that from his initial presentation, he was discharged actually almost 2 months after. But after his initial presentation for CIED infection, he went home 28 days later. Of course, these patients often require prolonged antibiotics, a contralateral implant where indicated as it was in him, and then sometimes optimization of other medical problems, renal dysfunction, anemia, and a host of other comorbidities, which often go hand in hand with older patients with more complex devices. And so what's already been demonstrated is that delayed extraction does increase morbidity or mortality. And as Aldo has already shown in his slides, whether it's a bacteremia or a pocket infection, early extraction is associated with improved outcomes, as can be seen by this Kaplan-Meier graph. And this was in cases dichotomized by extraction in before or after 7 days. So CIED infections can present in a range of different ways, and this Venn diagram nicely describes the different ways they can present. Sometimes it's not at all obvious, and sometimes it may be an isolated bacteremia that we need to hunt for the source. And it's particularly difficult when the pocket looks completely benign. There's no evidence of an infection or a clear erosion, as is clear cut on the right-hand side. And this is where it's also quite difficult, because sometimes patients may actually have a little bit of inflammation and they may have a superficial incisional infection. Now, this ERA consensus statement nicely describes the pathway for these patients. And as you know, patients who have a pocket infection or bacteremia and CIED-related infection all require total lead extraction, but patients with a superficial incisional infection may actually be able to be treated with simple antibiotic therapy. And the challenge is to differentiate these. This can be really, really difficult. And the only way to do that is to observe the patients, often over a period of time, and review them. And we'll come back to that point in a minute towards the end. So a slide just to highlight, I guess, what has already been presented by Joachim, which is that often the further away that patients are from expert EPs that actually undertake lead extraction, the less familiarity there is with the guidelines. We can see here that a case with a swollen device and fever with suggestion of a CIED infection, EPs generally tend to get a reasonably high proportion of them would be familiar with the guidelines and refer for appropriate extraction, but primary care physicians and more general cardiologists who do not do lead extraction may opt for antibiotics alone, and indeed not even refer them for lead extraction. So how can we improve this? As Richard already alluded to in the discussion before, sepsis and the early identification of sepsis is absolutely key and has been a real priority over the years in multiple healthcare organizations. Reducing the time to antibiotics is a really important step in reducing ITU stay and improved survival. And you can see here that in this before and after study using best practice alerts, the time to antibiotics was reduced to from just over an hour to just under half an hour in this study. So what about EMR notifications with respect to devices? We mentioned this briefly just before. So there isn't a lot of data, but there is some data that is giving us a signal that maybe this is the way forward to help identify these patients. We know if patients have a device that's logged usually on their electronic medical record, and we can also identify patients that have been given antibiotics or have positive blood cultures. This is one such study that generated a lot of EMR notifications. Many of them, as you can see, were not related to CIED-related infection. Patients may have had a device and pneumonia in this scenario. But of the patients that did go and have a device-related infection confirmed, just under half here underwent lead extraction. And now part of the problem is that some patients may have a pocket-related infection and no bacteremia. And so obviously for patients where we are identifying them via bacteremia positive blood cultures, they would not be alerted through this system. Another such example using EPIC, which is the system we have at Guy's and St. Thomas's. This is a study from the US, again, using positive blood cultures and identification of a CIED on the alert, best practice alert panel, being able to identify a large number of patients with bacteremia. In fact, there were a large number of contaminants in these in this specific study. And again, this showed a reasonably small number of patients with confirmed lead and device-related infection. But before and after this intervention with the best practice alert, the time to consultation was reduced from 4.5 to 2.5 days. And there was a trend, although statistically not significant, time to reduction to lead extraction from 11 to 9 days. Again, this is small numbers, but again shows that simple implementations of EMR notifications may be able to identify these patients early. And finally, another study using the EPIC best practice alert system, whereby CIED and a bacteremia would trigger an alert. There were, again, a reasonably small number of patients who actually underwent lead extraction in this study. But again, time to echocardiography and time to consultation was significantly reduced by using this intervention. So even though the numbers are relatively small, this does suggest that using such notifications is a relatively easy way to try and bring this really important topic to the forefront of the minds of physicians that are treating patients who have devices. But one of the other ways to do it, I would argue, is through empowering our patients. So when we send a patient home with a device, we give them leaflets, we give them the do's, the don'ts, what to do, what not to do, and the red flags to look out for in terms of heat, pain, redness, and swelling, and also systemic upset. And we want to be able to tell them who to call and where to present. And I think sometimes this is where the problem lies, and that patients are not educated enough about their devices, and they really need to be. They need to be engaged in the process, because the patient really needs to be the channel through which early identification of infection can be done. So we can disseminate information through lots of different ways now, and these digital animations are some examples of that. The video on the left is one produced by ERA and is a good example of how we explain to patients what to look out for, again with the device giving pictures, and actually patients can take pictures of their device and send them to their physicians through Epic and other EMR systems, and this can be particularly helpful in order to identify infection early. Finally, the video on the right, I'm not sure if it is playing or if someone can hit play, but this is a video that we use as part of the consent process for patients undergoing lead extraction, and it helps to explain the nature of the procedure and the risks. And again, this is part of making the patient a central part of their journey, such that we're not dealing with a paternalistic model, as was the many years ago, but the patient is central to the discussion and understands what's going on. Just in brief, a look at our arrhythmia nurse-led wound clinic at Guy's and St Thomas's. So this is a clinic recently set up to look at patients who may have concerns about their wounds and who may need further diagnostic workup. This is data from really just over a year, demonstrating with 75 patients that actually most of the time, just over 50% of the time, we were able to reassure and discharge patients. But sometimes patients required further diagnostics to identify any potential infection. And you can see that of the 34 patients that did need further diagnostic workup, a couple required direct admission, some required further review and were able to be discharged, and some had a superficial infection for which they were given antibiotics. And critically, as I mentioned earlier, re-review of these patients is absolutely key, so that one can decide whether actually one is dealing with a superficial infection or they are dealing with a more deep pocket infection, which requires lead extraction. So I think that in 2025, the patient-doctor partnership is absolutely key. And this is where I think the patient really needs to be central. The patient needs to be able to ask questions, to express concerns. If they have concerns about their device, they can take pictures so it can be reviewed over time. We know that infections don't always occur early, and some do indeed occur late and can take a very long time to develop. So encouraging that engagement with patients through their electronic medical record, I think, is key, and utilizing patient support tools as well is going, I'm sure, to result in improved CIED patient outcomes. So in conclusion, I think we've demonstrated throughout this session that we know CIED infection requires prompt identification and treatment, and often that delay in both the presentation and the management of lead extraction will worsen clinical outcomes. There is a real clinical challenge with superficial and pocket infections and identifying which is which, and EMR alerts may help to early identify such infections. And finally, empowering patients through education is absolutely critical. Thank you very much.
Brilliant. Thanks, Jonathan. Let me get straight into one of the questions we've been asked by one of the audience. Is there any benefit in initial antibiotic prophylaxis or treatment for pocket infections while awaiting extraction? And is there a danger that when you see the drop in CRP, it gives them false reassurance that the infection is being treated and extraction isn't needed? What's the role of early antibiotics in this scenario, Jonathan?
So I think that antibiotics are key, and as our microbiologists are keen to tell us, identification of the microorganism is absolutely paramount. So multiple sets of cultures and indeed wound swabs if the wound has, if the device is eroded, is absolutely key. But I think once the decision or the diagnosis has been made of a CIED pocket infection, a timely and early lead extraction is absolutely critical. One such case we actually had yesterday really exemplifies that. Often, as you say, the patient can get better after use of antibiotics, and you can think, oh, okay, I've got this under wraps. The patient's getting better. No need for lead extraction. Patient had pus in the pocket. So I think ultimately, if you've made a decision that the patient has a device-related pocket infection, they require a lead extraction, and the antibiotics are part of that. But almost always, they will need an extraction.
One of the questions, and maybe I can put this to Joachim and the others as well. Are there patients who are more prone to device infection, and is there a way of identifying them and singling them out for particular education or pre-treatment, Joachim?
Well, I think every patient who's immune compromised in a way has a higher risk of infection. Maybe patients who have manipulations going along with bacteremia in a way. So let's say the tooth, for example, if they have major operation in the tooth, you should always think about it. I really like what Jonathan raised. So I think we really need to train our patients as well. We, as implanting physicians, we should inform all our patients, and I think it's not routinely done in daily practice, about pocket infection on one side, but on the other side also on fever of unknown reason. If they have fever and nobody can really explain it, they should think about an infection of their device as well.
Great, and I think there's a very nice paper written by my colleague Ed McLean, which I think a few of you are authors on, the blister score. That seems to be a very nice way of predicting who's going to be at higher risk of infection, who might need some form of antibiotic pocket. Aldo, we're being asked, what risks do you and complication rates do you quote to patients when you're doing extraction of infected devices?
Yeah, thanks, Richard. Clearly, discussing the risks of the patients is key. As you know, in lead extraction, a lot of the risk is related to the lead dwell time, so how long a lead has been in the patient, and the longer, the higher the risk. Also, there are patient-specific risks as well. At Guy's and St. Thomas's, we use a traffic light system, which is based upon several different factors, patient characteristics, lead dwell time, and we tend to categorize patients into green, amber, and red extractions. And those very high-risk extractions, which we class as red extractions, we usually quote something like a 5% risk of a major vascular or cardiovascular complication, with a less than 1% risk of mortality. The ambers will be lower. The green patients will be even lower. So it really is very specific depending on both the patient characteristics and the device characteristics. But clearly that discussion with the patient up front and with the family, importantly, prior to any intervention, is key so that a shared decision can be made.
Brilliant. And coming back to Ernest's question, Jonathan, do you advocate capsulectomy at the time of extraction, or indeed at the time of box changes? Is there evidence that the inert capsule can be a nidus for infection?
Yeah, so I mean, I think that certainly if you have an infected device, then wash out of the pocket and removing necrotic and infected material is important. Often these wounds do take a long time to heal, and reinfection with hematoma that then is a nidus for infection, I think, is really common. So removing that, yes, for infection. With respect to box changes, I'm not sure I would necessarily advocate that. I think sometimes less is more. Longer procedures, longer procedure times do increase the risk of infections, and we know that box changes themselves do that as well. So yes, the box changes themselves are a risk, but I wouldn't advocate complete capsulectomy for those non-infected patients undergoing elective box change.
Brilliant. Well, I think that's been an amazing and really informative session. Thanks to Jonathan, Aldo, and Joachim for their excellent contributions. I think what we've learned from this session is that early device extraction is really important for infected devices. Educating our colleagues who implant but don't extract is critical for patients to get access to the appropriate treatment as soon as possible. And Jonathan's point about making sure the patients are partners in this process and they understand what's needed and where they should go if there's signs of infection was a really important one, because often many patients are highly involved in their care. Stay with us. The next session is coming right up.